Hello everybody. Today we are going to discuss management of the potential organ donor ICCM guidelines. So the role of intensivist. The ICCM recommends that trained critical care person should involved in the management of the potential organ donor. The ICCM also recommends for the early identification, assessment and maintenance of potential organ donor. ICCM recommends that intensivists play a vital role in evaluating deceased donor. So regarding role of intensivist, early pickup of early pickup of brain death the alert sign and recognize the potential organ donor, maintaining hemodynamic stability to improve the organ quality, diagnosing and certification of neurological death, preparing the family for devastating news, counseling family for end of organ life, then implementing policies and protocol for optional for the option of organ donation, then communication with transplant coordinator, organ procurement team, and family members, handover protocol to the organ procurement team. Then diagnosing brainstem death. For declaration of the brainstem death, there should be potential irreversible cause of catastrophic brainstem injury. Confounding criteria should be ruled out. Preconditioning criteria should be checked. According to the Transplantation of Human Organ Act 1994, the definition of death is defined as follows. Deceased person means a person in whom permanent disappearance of all evidence of life has occurred by reason of supported brainstem death or by cardiopulmonary arrest. In cardiopulmonary sense, at any time after live birth has taken place. Brainstem death means stage at which all function of brainstem have permanently and irreversibly ceased. However, a cause of irreversible coma has to be established, and the precondition should be made, and confounding factors are to be ruled out. Preconditioning includes core temperature more than or equal to 34 degrees Celsius, metabolic parameters within the acceptable range like sodium, potassium, acid, base, no endocrine disturbance, and drug intoxication ruled out. So brain death is commonly caused by spontaneous intracranial hemorrhage, head injury due to motor vehicle accident, recreational and industrial accident, gunshot assault, cerebral anoxia, ischemic injury, cardiac arrest due to asthma, asphyxiation, drug overdose, carbon monoxide poisoning, primary cerebral tumor. So this is the prerequisite for brainstem death diagnosis, that is established irreversible cause of coma supported radiologically. Plus there should be the absent brainstem reflex. Apnea test should be positive. Then all the preconditions should be made. Confounding factors should be ruled out to diagnose brainstem death. Then this is the structure of National Organ Transplantation Program. The Director of the General Health Service Ministry and Health and Family Welfare. Then there is a National Organ Transplant Protocol. At national level, it is known as NOTO, that is National Organ and Tissue Transplant Organization. At regional level, it is known as ROTO, that is Regional Organ and Tissue Transplant Organization, and at state level, it is known as SOTO, that is State Organ and Tissue Transplant Organization. Then the Transplantation of Organ Act legislation has made disease or donation legal activity. Then this THOA 1994 was amended in 2011, and the amended act now named as Transplantation of Human Organ and Tissue Act. So this quota 1994 provides the regulation of removal, storage and transplantation of human organ and tissues for therapeutic purpose and for the prevention of commercial dealing in human organs and tissues. So evaluation of potential and disease organ donor should include history taking, physical examination, exclusion of confounding factors, performance of complete neurological examination and apnea test. So confounding factors that interfere in the clinical diagnosis of brain death, that is shock, hypotension, hypothermia, temperature below 32 degrees Celsius, neurotoxic snake involution, brainstem encephalitis, Guillain-Barré syndrome, encephalopathy, severe hypophosphatemia. Drugs are known to alter the neurological, neuromuscular function and EEG testing, such as anesthetic agent, neuroparalytic drugs, sedatives, GABA antagonist, and ethanol. Then complete neurological examination include the following, that is examination of the patient for response to noxious stimuli administered through cranial nerve pathway should be carried out. Suggested sites for the noxious stimuli are supraorbital groove, trapezius squeeze, condyles at the level of temporomandibular joint and the sternum. Then history of severe neuromuscular injury, facial trauma, as this condition potentially masks the motor response. It is necessary to differentiate spinal from the brain-mediated motor response. Finding in the brainstem death patient include absent pupillary reflex, absent corneal reflex, cuff and gag reflex will be absent, and absence vestibular reflex. So apnea test is mandatory in confirming diagnosis of brainstem death. Apnea test is performed only after prerequisites are made and thorough examination of the brainstem reflex is done. So absent respiratory effort in the presence of hypercarbia is the principle of apnea test, and the following prerequisite must be made before carrying out apnea test. That is core temperature more than 36, euvolemia positive fluid balance in previous 6 hours, normal PaCO2 and PCO2 above more than or equal to 40 mmHg, then normal PO2, pulse oximetry, ECG monitor, blood pressure should be monitored continuously. Then following are the steps to be followed at apnea test. That is pre-oxygenate the patient with 100% O2 for 10 to 15 minutes and do an ABG analysis on this ventilator setting. A curtain should be used while carrying out the test. And then check for pulse oximeter, ECG monitor, and BP monitors. Then patient chest and abdomen should be exposed. Disconnect the ventilator. Deliver 4 to 6 liter per minute of O2 through endotracheal tube into trachea using soft catheter. Then look closely for any respiratory movement, that is abdominal or chest excursion, that produce adequate tidal volume. Then after 8 to 10 minutes, send the ABG. For every minute of apnea, PCO2 rises by approximately 3 mmHg. If respiratory movements are observed, the apnea test result is negative. That is, it does not support the clinical diagnosis of brain death. Then connect the ventilator if during testing systolic blood pressure becomes below 90 mmHg or below age appropriate threshold in children below 18 years of age, or pulse oximetry indicates significant oxygen desaturation or cardiac arrhythmia development. Then interpretation, if respiratory movements absent and arterial PaCO2 more than 60 mmHg or increase in PaCO2 by 20 mmHg above the baseline PaCO2, then apnea result is positive. If PCO2 is below 60 mmHg or PCO2 increases below 20 mmHg over baseline, the test is indeterminate and confirmatory test can be considered or apnea test can be repeated. Then complication of apnea test are hypotension, hypoxemia, cardiac arrhythmia, cardiac arrest, pneumothorax, pneumomediastinum, and pneumoperitoneum. So apnea test should be done twice, that is 6 hours apart by registered medical practitioner. Troubleshooting during apnea test, hemodynamic instability occur, then step up hemodynamic monitoring, titrate vasopressor and inotrope and hormonal replacement, then recurrent desaturation, adequate pre-oxygenation, recruitment maneuver, apnea test with PEEP valve and Bain circuit. Then for chronic CO2 retainer like COPD and baseline CO2 is high, then target CO2 more than 20 mmHg above baseline. Metabolic factors, that is lower high blood sugar, hypernatremia, acidosis, and CO2 less than 35. Do not do apnea test. First correct the metabolic parameter. Then patient on ECMO, reduce the sweep flow in VV ECMO. Then steps for apnea test for patient on VV ECMO. Pre-oxygenate with 100% FiO2 with ventilator and 100% O2 on ECMO flow at least for 10 minutes. Reduction in sweep gas flow at 0 to 1 liter per minute. Either continue to keep the patient on ventilator or disconnect. and take on TPs or insert insufflation cannula. Then inside the TT with oxygen flow at 6 to 9 liter per minute or use CPAP. Do blood gas analysis before reducing gas flow rate and observe SpO2 and respiratory movements. Intensivists should be aware of compatible and incompatible observations seen in brainstem death. Compatible observations like spinal reflexes, sweating, blushing, tachycardia, normotension with pharmacological support, absence of diabetes insipidus, incompatible movements like decerebrate or decorticate posturing, extensor or flexor motor response to painful stimuli, and seizures. Then reason for spinal reflexes. The reflex movement represents the hypoxia and hypercarbia induced activity of cervical cord neuron. They might be due to disinhibition of the movement generator of spinal cord, mechanical compression and the decompression of spinal root or cervical spinal cord by neck flexion or extension can generate the movement. Then regarding ancillary tests are not mandatory for diagnosing brainstem death. Ancillary tests should be conducted if panel of doctors are in doubt or disagreement with the diagnosis to establish clear irreversible cause of brain injury or if there is any contraindication to carry out clinical examination. As per TOHA, the ancillary tests are not mentioned at all, hence its legal acceptability challenging. Harvard brain death criteria were initially proposed and the EEG was recommended for every evaluation. Listen, the following are indication listed in the following are the indication for ancillary tests, that is patient with the cranial and cervical injuries and cardiovascular instability, severe facial trauma, otorrhea, otorrhea, eye agenesis preclude the performance of clinical examination, panel of doctors who are in doubt or disagreement with the diagnosis, establishment of clear irreversible cause of brain injury, exclusion of confounders and persistent coma. Then the recommended ancillary tests are DSA, that is lack of contrast opacification, indicate no flow in the intracranial vessel while extracranial flow is present. It is a gold standard and 100% sensitivity and specificity. Limitation, expertise required, cost transfer, hemodynamically unstable patient to characterization lab is difficult. Then radionuclide imaging, lipophilic and lyophobic technetium produces the signal as they move intracranially or pass through the blood-brain barrier and are metabolized by metabolically active parenchyma. The sensitivity and specificity is similar to DSA. The patient need to be transported to scan department. Lyophobic compound inadequately demonstrate flow through posterior fossa, hence lipophilic compounds preferred. Then transcranial Doppler, it measures the dynamic blood flow to the brain and it confirms the circulatory arrest. That is anterior and posterior circulation. It is portable, easily performed bedside, two examination at least 30 minutes apart. It is not suggested in pediatric. 10% patients have poor bone window procedure affecting flow dynamic interfere in the interpretation. Then CT angio, peripheral injection of iodinated contrast and evaluation after 25 to 40 seconds. Absence of intracranial flow with the persistence in the extracranial carotid circulation. It has ease for use, speed, and the wide availability. Then stasis filling transportation to the radiological department. EEG, it detects only cortical activity. It is a portable. Inference by the bedside monitor, TTM, or sedation, lack of ability to assess posterior fossa and brainstem. Then patient who are on ECMO, in patient who are on ECMO supports the detailed a clinical examination should be carried out. While performing apnea tests with flow rate, that is CO2 clearance rate, should be decreased to 0.5 to 1 liter per minute. In patient treated with TTM, evaluation for brain death and death by neurological criteria cannot be initiated until at least 24 hours following complete reward. Certification of the brainstem death. The Isccm recommended that certification of the brainstem death patient disease organ donor be done by a registered intensivist, medical practitioner, anesthetist, neurophysician, neurosurgeon. Clinical examination and apnea test need to be done 2 times 6 hours apart by two doctors who do not belong to retrieval and transplantation team. Documentation should include the patient's identification, the potential cause of brainstem death, clinical and neurological findings, and the apnea test interpretation. All four doctors, that is member of panel of board of medical expert, should sign the test done to document the absence of brainstem function. Certification of brainstem death requires the panel of four doctors, that is the doctor in charge of the patient, doctor in charge of the hospital where patient was treated, independent specialist of the unspecified specialty, that is physician, surgeon or intensivist, nominated from the panel of names approved by appropriate authority, neurologist and neurosurgeon. Form 10 should be filled and signed by medical expert in certifying brainstem death. Amendments in the TOHA 2011 and THO 2014 rules have allowed the selection of surgeon, physician, anesthetist, and intensivist in the event of non-availability of neurosurgeon and neurologist. What needs to be included in the medical record documentation? The eligibility, etiology, and the irreversibility of the coma and unresponsiveness, absence of motor response to pain, absence of brainstem reflex during two separate examinations, separated by at least 6 hours, absence of respiration with PCO2 more than 60 mmHg, justification for and result of confirmatory test if used. The Isccm recommends communication with the next of kin be carried out in stepwise fashion regarding severity of illness of the patient and brainstem death state. The transplant coordinator of the hospital plays a vital role in communication and obtaining consent for organ donation along with intensivist. It is necessary to inform about organ donation consent to station house officer or superintendent of police and deputy inspector general in case of a documented medical legal case. The process of consent for organ and tissue donation involves the following: disease, wishes, and willingness, next of kin, and coroner consent. Then this to THOA amendment, that is 2011 rules 2014. It allows the transplantation of organ and tissue from living donor and cadaver. Appropriate authority approves the panel of RMP and also provides the certification of transplantation and retrieval. Any hospital with ICU facility and requisite system can register with a appropriate authority as a retrieval center. Brain death committee consists of four physicians, the RMP in charge of hospital, the RMP independent specialist, neurologist, neurosurgeon, and physician in charge of case. In case of non-availability of neurophysician or surgeon, any appropriate authority approved surgeon, physician, anesthetist, and ICU specialist can stand in. Testing is done by one of the member to be witnessed by the other and all four sign the document. Apnea test only if other tests are negative. For adult, two sets of tests with observation period of 6 months. Isccm mandates the certification and notification on all brain dead irrespective of organ donation. Isccm recommends the critical pathway for sequential task in disease organ donation program. This is to maintain the uniformity of organ donation program in all institutes, prevent the potential conflict of interest, and help to run organ donation program with public trust. Isccm recommends that intensivist along with procurement team member evaluate the organ donor meticulously, perform detailed physical examination, detailed history, finally perform investigation including biochemistry, radiological, organ-specific investigation like HRCT, bronchoscopy, transesophageal echocardiography, necessary procedure to evaluate quality of the donor. Then ICCM also recommends the absolute contraindication of organ donor under heading of metastatic malignancy, infection, and organ-specific end-stage disease. Now the management of organ donor, that is early identification of potential brain dead donor and declaration of death by treating team. Eligibility of the donor, like history, based on history, investigation, infection, malignancy. Counseling and consent of kin for organ donation. Social worker and coordinator along with intensivist and admitting consent. So once consent is given, send investigation. Donor hospital transplant coordinator inform donor information to ZCCC and SOTO. Then inform SHO or DSP of local police station and forensic medical officer about brain death and plan for organ retrieval in medical legal. Then SOTO coordinate allots the organ time of or for organ retrieval surgery is determined and communicated to relative. Then organ retrieval surgery, organ quality, shape, standard, and expanded criteria organ informed to SOTO coordinator. Joint and family prayer allowed before shifting donor to organ retrieval surgery. Then transplantation center admit the eligible recipient and prepare for transplantation procedure in accordance with expected time of organ arrival. Body is handed over to the relative in ICU. Document bill of donor maintenance to SOTO, which will be paid in proportion to organ received by receiving hospital. Adverse effect to recipient are informed to SOTO within 7 days of transplantation. Special points in history and investigation required for pre-retrieval screening, like point in history before organ donation, infection in current and recent admission, the use like topical infections like dengue, malaria, chikungunya, lepto, use of live vaccines, occupational exposure, recent international or domestic travel history, recent transfusion with the blood products, any contact with people with HIV, HPV, HCV, or transmissible disease, tattooing, ear piercing, body piercing in past 6 months, use of illicit drugs, unsafe sexual practices, or history of any malignancy. Then all donors collect undiluted blood sample, collect blood count, serum electrolytes, and creatinine, chest X-ray, ABO blood group, and RH typing, HLA typing, infectious disease screen like PSMP, dengue NS1, salmonella, chikungunya PCR, rickettsia PCR, topical fever, multiplex PCR, blood urine sputum culture, HIV-1, HIV-2 antibody, HCV antibody, HBsAg antigen by ELISA. Then NAT testing for HIV, HBsAg, and HCV to avoid antibody window period of false negativity. Antibodies for CMV, EBV, toxoplasma. A plasma and serum sample must be drawn within 24 hours of procurement and stored frozen for 10 years for detection of donor-retrieved infection disease retrospectively should they occur in recipient. Then regarding kidney, BUN, creatinine, urine analysis, urine culture, USG abdomen and pelvis, biopsy if indicated, HTLV antibody, liver, AST, ALT, alkaline phosphatase, total direct bilirubin, gamma glutamyl transferase, S protein, PT-INR, PTT, fibrinogen, take biopsy if needed. Then HCV uh, if needed, then USG abdomen, pelvis, heart, in case of heart, 12-lead ECG, 2D echo, cardiac enzyme, NT-proBNP, coronary angiogram if donor is more than 40 years. In case of pancreas, serum amylase, lipase, and USG abdomen. In case of lung, chest X-ray, ABG, sputum gram stain, culture, and bronchoscopy. Then list of absolute contraindication, malignancy, exclude the patient who are treated and free from malignancy more than 5 years, metastatic malignant neoplasm, acute leukemia in progress, acute lymphoma, melanoma with less than 5 years of follow-up, pulmonary microcytoma, multiple myeloma in progress, then infections, bacteria not contraindication but caution is advised, treat with appropriate antibiotic for 48 hours, HIV infection, severe systemic infection, intracellular pathogens such as Listeria, Trypsonoma, untreated infection of unknown origin, untreated encephalitis of viral origin, Febrile meningoencephalitis of unknown origin, active infection due to fungi and other opportunistic organisms, infection with no treatment options like rabies, dengue within their infectious and transmissible period, then chronic end-stage organ like cirrhosis of liver for liver donation, CKD for kidney donation, cardiomyopathy with ejection fraction less than 40%, left main triple vessel coronary artery disease for heart donation, advanced COPD and ILD for lung donation, pancreas, history of diabetes mellitus, history of chronic alcohol use, history of pancreatitis, pseudocyst, pancreatic surgery. Regarding intestine, extensive atherosclerotic disease of aorta and superior mesenteric artery. Now, the classification of the tumor donor to estimate risk of transmission. Absolute contraindication, all cerebral lymphoma, all secondary intracranial tumor, all cancer which spread outside the organ of origin, active hematological malignancy, then with high risk of more than 10% risk of transmission, malignant lymphoma, breast carcinoma more than stage 0, colonic carcinoma, choriocarcinoma, CNS tumor, with VP or VA shunt surgery, CNS tumor with WHO grade 3 and 4. Then intermediate risk like 1 to 10%, breast carcinoma, colon carcinoma, solitary renal cell carcinoma, history of treated non-CNS malignancy with probability of cure between 90 to 99%. Then low risk, that is 0 to 1% risk of transmission, that is solitary renal cell carcinoma, low grade CNS lymphoma, primary CNS mature teratoma, solitary papillary thyroid carcinoma, minimally invasive follicular carcinoma of thyroid, history of treated non-CNS malignancy. Then minimal risk, that is less than 0.1%, basal cell carcinoma, squamous cell carcinoma, skin without metastasis, carcinoma in situ, cervical carcinoma, vocal cord carcinoma, superficial papillary carcinoma of bladder, solitary papillary thyroid carcinoma, minimal invasive follicular carcinoma, and the no significant risk, that is brain. Then standard and expanded criteria for organ donation. For regarding kidney donation, age should be less than 50 years. Cause of death due to brain death due to isolated head injury and medical condition like stroke. Normal renal function, no hypertension requiring treatment, no diabetes mellitus, no malignancy other than primary brain tumor and treated with superficial skin cancer, no generalized viral and bacterial infection, acceptable urine analysis, negative assay for syphilis, hepatitis, HIV, and human T lymphotrophic proliferative virus. Then expanded criteria are age less than 6 years, age more than 60 years with other parameters normal, age 50 to 59 years plus 2 of the following like hypertension, cerebrovascular death, pre-retrieval creatinine less than 1.5, elevated creatinine up to 3 is not contraindication, especially if creatinine level is falling and if donor is known to have normal renal function in recent past. Then regarding liver, macrostasis of less than 30%, age less than 70 years, hemodynamically stable and low dose inotrope, no hypotension less than 60 mmHg for more than 1 hour, transaminitis less than 10 times, bilirubin less than 5, negative blood culture within last 5 days, then anti-HCV, HBsAg, anti-HBC antibody, HIV should be negative. Expected cord ischemia time is less than 10 hours. Last pre-retrieval serum sodium is less than 160. Then regarding expanded criteria, microstasis more than 30%, age more than 70 years, high inotropic supports, then transaminitis more than 10 times, cholestatic liver, bilirubin more than 5, positive blood culture within 5 days, anti-HCV, HBsAg, HIV positive, expected cold ischemia time more than 10 hours, then partial split graft, Last pre-retrieval sodium more than 160. Additional ECD points for Sotiopoulos book on liver transplant, that is obesity, ICU stay more than 5, prolonged hypotensive episode of more than 1 hour, cardiac arrest, CPR, cold ischemia time more than 10, 12 to 14 hours, peak serum sodium more than 150 or 150 to 155, alcoholism, bilirubin level more than 2. Then regarding heart, hemodynamically stable with inotropic support, donor age less than 60, no significant coronary artery disease, no history of heart disease, no significant structural heart disease, ejection fraction more than 45%, weight size matching, cardiac arrest, donor retrieval after brief cardiac arrest must be assessed extra carefully, but can be considered if cardiac function is normal. Then extended criteria age up to 65, undersizing and oversizing of more than 20% of body weight, high dose pressure requirement, prolonged hospitalization, significant but correctable valvular dysfunction by echo, history of chest trauma, significant CAD and history of coronary artery disease, elevation a significant CAD or history of myocardial infarction, but bypassable one or two vessel coronary disease, elevation of myocardial enzyme, prolonged CPR for more than 5 minutes, then transient hypotension, open cardiac massage, significant cardiac abnormalities. Then refractory arrhythmias, ejection fraction less than 45, wall motion abnormality, then cold ischemic time 4 to 5 hours. Then regarding lung, age less than 55 years, ABO compatibility, clear chest radiograph, PO2 more than 300, then cigarette less than or equal to 20 pack per year, smoking history, absent chest trauma, no previous surgery on side of harvest, no active sepsis, malignancy in lung or outside, no history of significant COPD, no aspiration sepsis, absent of purulent secretion, sputum gram stain, free of significant number of bacteria. Then expanded criteria include age more than 55, PO2 less than 140, smoker more than 20 pack per year, absence of history of lung disease, mild asthmatic donor. Then last moment rejection, inability to recruit, unacceptable PF ratio, unanticipated confirmation of primary and non-primary malignancy, severe trauma not appreciated on CT, new data non-compatibility, demise of original recipient during transit, withdrawal of consent from donor's decision maker. Regarding pancreas, age less than 55, BMI less than 28, no history of diabetes mellitus, no history of alcohol use. Donor hyperglycemia may be acceptable, HbA1c less than 7. Regarding intestine, age less than 65, BMI less than 30, hand weight and size are matching, no trauma to limb being procured, no neurological disease, no implant outside the limb being procured. Thank you.